I often will tell people this, the first 5 years of my career, it was almost exclusively oncology, right?
Oh
Yes,
my
it
God, I
was
love that.
pelvic health, but it was
Hmm.
oncology. I was working in a clinic where I was starting to see trends that kind of was like the beginning of advocacy for getting women in early to physical and occupational therapy after
Yes.
hysterectomy, after mastectomy associated with cancer treatment, because in 2 or 3 weeks' time, they were going to be hit with chemo, with radiation, all of those things that really slows down healing.
Yes.
And they didn't even have any kind of post-op rehab to just start
Hmm.
moving in a way that helps with tissue repair and healing. But it was the moment that I had a mom just given birth, then be scheduled for a double mastectomy. I was just like, whoa, for stage 3 cancer. Like she had
Right.
just
Right.
given birth. There was like no bonding period. I'm talking about within 3 weeks of giving birth, they were like, okay, we have to schedule you for double mastectomy. It was
Oh my
wild.
God.
At least I cannot tell you like the amount of trauma that we work through during that whole year of just
Yeah.
postpartum recovery, mastectomy recovery, and then she
Hmm.
had started chemo, just within the next few months. So it was just
Oh
like
my
boom,
God.
boom, 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 boom. And I realized not only are we putting people at a disservice, right, after they give birth, but for people just hit with a diagnosis of cancer
Hmm.
and then pushed into this factory mill of treatment, 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 with like no kind of breather of just like, hey, here's what's going to happen. Let's prepare you for that with rehab.
Hmm.
Or you just had a baby and now you're going to start treatment for cancer. Let's prepare you for that. And I realize either I'm going to burn out or I have to do something. I have to change this. And so, like, just starting this podcast off with you, no, contact me, contact anyone. If you see even just one patient like that who had given birth and now is going into cancer treatment, there's nothing that I know or that I feel is proprietary enough to not share it at this point in my career, to
Hmm.
not talk about
Hmm.
it.
Sometimes, as an onco PT, we encounter topics that we're not very comfortable with, and they can be very intimidating. And I know that was definitely me when it comes to our topic of the interview today, because I actually had this episode drafted in a folder for over a year before I finally pulled the trigger and reached out to this guest, because she is so cool, y'all. I couldn't wait to get her on, but I just was really intimidated. And so yesterday, literally yesterday, I said, Elise, you gotta pull the plug, right? You gotta go, you gotta ask her. And graciously, not only did she say yes, but she also booked an interview for the very next day. So here we are. If you don't know her already, you are going to love her. And I'm so thrilled to welcome Dr. Rebeca Segraves to the Onco PT podcast. Welcome, Rebecca.
Thank you, Elise, for having me. That's truly, truly, truly. I'm just humbled and honored to be on.
It's about time, like I said, because I literally was so scared. I was like, gosh, if I don't think about this topic, if it just sits in that draft folder, like I don't have to think about how much I don't know about it. But we're diving in headfirst today. So, Rebecca, would you mind telling my audience just a little bit about you and some of the things that you enjoy practicing and teaching on so we can get started with it?
You got it. Yeah, so I'm a physical therapist by background. I specialized early in women's health, went through a residency at Duke, and actually, first day of residency, I saw 5 patients with lymphedema, whether it was cancer related,
Whoa.
vascular related. That was like my deep dive into the residency, just out of PT school.
Mm-hmm.
So I started with oncology, I feel like day one of my PT career, and practiced almost exclusively with oncology patients for about 5 years before I started to do a little bit more with maternal health and specifically inpatient maternal health. So I worked at a large hospital that saw about 500 births a month, and we were the first perinatal care facility. So that's a level 4 equivalent to a level 1 trauma center we saw in the largest hospital system in the Texas Medical Center for that population, every mom after C-section in the hospital before she was discharged, we were able to get a program up and running that offered physical therapy services to that population within about 6 months of starting the efforts and getting the ball rolling with physicians and getting them very used to the idea that physical therapy should be offered to this
Mhm.
population. So I've been doing that for a while, and even early in my career with oncology, I started to teach non-onco physical and occupational therapists. So those who were more orthopedic, uh, neurologic background, what they should look for in patients who had undergone chemotherapy, radiation, oncology surgery. And so even then, I was accustomed to teaching non-pelvic health, non-women's health, non-oncology providers what to look for in these patient populations because there were not enough of us. There were not enough oncology PTs and OTs. There were
Mhm.
not enough women's health or pelvic health PTs and OTs. And so I found that I could build a team if taught the acute care therapist or the orthotherapist, outpatient therapist, how to treat these early issues before they became lymphedema or radiation fibrosis or issues later on down the road. So that's really how I've started, and I've been really on the early intervention train for a while.
I'm already blown away by all of this because it's like it should not be mind blowing, but it is because I think of how little it's actually happening in practice. And I'm super obsessed with the fact that you're doing it. Can we go back a minute? Did you say that was in Texas? That early work?
Yeah, yeah. Well, with the maternal health population and early oncology was in North Carolina.
Okay, so I'm in Fort Worth, Texas, which I was like, "Oh my god, where is this? And can you please come to Fort Worth because we have like my so Fort Worth within the county within the state of Texas, we have one of the worst maternal mortality rates in the United States. Like it is horrendous. Anyways, that could be a whole podcast episode in itself. So, anyways,
Wow.
it is needed very immediately in my area. What I would really why I brought you on the podcast because I could rant about that all day every day is more on the oncology, the intersection, the frankly, I think collision that sometimes happens between pregnancy, postpartum, and cancer. And in my career, I've actually only ever seen one patient, and she was not actually even my patient. I've only actually seen one patient who was pregnant at the time that she was undergoing cancer treatment. Now, this happens. I know that I haven't seen the one patient who's experienced this, but what I have seen a lot more of is patients who are immediately postpartum, like they gave birth maybe a couple months ago, earlier in the year, and now they're starting breast cancer treatment, for example. That's typically what I see the most of. And while I don't know what I'm missing, I know I'm missing a lot. And I bet my listeners are feeling the same thing. So, can we chat a little bit about, let's talk just pregnancy, postpartum first. What are some of those common pelvic floor issues that patients are facing that we need to be aware of?
Yeah, I mean, honestly, it can range from just basic vital signs assessments that are missed in the hospital because standard practice places moms postpartum, individuals after birth, in a situation where they're only being assessed at rest. So just think about that. You've just given birth. You may have lost more blood than normal. You may have labored and then were pushed into an emergent situation where you needed to deliver by cesarean section.
Mm-hmm.
And your nurse is only assessing your vital signs at rest. So downstream would be the pelvic floor issues.
Uh-huh.
Upstream would be the cardiac injury that moms are facing in the first 6 weeks where we're not seeing them because it's magical to wait 6 weeks, right? So that magical period where we're just letting them rest, they're actually doing more activity that's demanding on their heart. and take that person and then expose them to chemotherapy within a few weeks' time if they've been diagnosed with cancer. And
Mhm.
so before I could even start really training pelvic health therapists, I realized I need to train acute care therapists to just
Mhm.
assess their vital signs, especially if they're a mom who won't have the support at home,
Mhm.
who has multiple children other than their newborn, who has to negotiate stairs, and who has a lot more demanding activity that they'll be doing. Standing in a hot shower actually
Mhm.
is more demanding metabolically, if I can say that, is more
Yeah.
demanding metabolically on someone's physiology than even walking a 6-minute walk at their own self-selected pace, right? It requires
Whoa.
more METs to stand in a hot shower than it does to do your self-selected walking pace
Mhm.
for 6 minutes. It's incredible when you actually look at the demand on someone who is normal versus someone who's lost a lot of blood after
Mhm.
delivery. And so
Mhm.
that's upstream from the pelvic health issues that I'm concerned about with this population. So I first and
Mhm.
foremost just teach cardiopulmonary practice in the
Yeah.
hospital for the maternity population. And then we start weaving in the complexities of what impacts their pelvic health later on, what impacts their heart later on, and how we should be preparing them for cancer treatment if they've been diagnosed during pregnancy.
Mhm. That's so much already. Like, I feel like we haven't even gotten to the pelvic floor stuff, and already we're facing, like you said, cardiopulmonary. It's so funny because, and I'm curious how you feel on this. The more specialized I become in oncology, the more of a generalist I find myself having to become. Like, I thought genuinely, which is silly, when I first graduated, I was like, I'm going to be in oncology and just all the oncology things. Now I'm like, I need all of the PT things to be able to treat this patient population. And that's not even including the pregnancy postpartum aspect of it. Like, holy cow.
Yeah. Lise, you said something so important that I teach students now. So I'm in a doctor of physical therapy program as an assistant professor. And I
Mm-hmm.
say all the time, you're graduating as generalists. However, when you choose to specialize, you're taking that generalist knowledge
Mm-hmm.
and you are zoning in on that specific patient population that you're choosing to specialize in. So if
Mm-hmm.
you're specializing as an orthopedic clinical specialist,
Mm-hmm.
you're taking your orthopedic knowledge, right? But that doesn't mean that you negate the fact that that orthopedic client may have cardiopulmonary issues, may have cancer related issues, may have reduced range of motion because they had a mastectomy,
Mm-hmm.
may have issues with getting in and out of bed because they just had an open abdominal surgery like a C-section. And now it's also impacted their pubic symphysis and their ability to walk.
Mm-hmm.
And so what I feel like is we've taken this our specialists, and we've said, no, we're only going to focus on the very narrow things within that patient population. And we're forgetting, no, that patient population also has a heart, they have a brain, they have a digestive system, they have a respiratory system, and that's all impacting their movement
Mm-hmm.
and their human experience, right? And their ability to
Yes.
function. So as a specialist, we never forget our generalist knowledge. We're just applying it to the patient populations that we've studied so hard to learn their
Mm-hmm.
whole journey as a patient.
Mm-hmm. It's I think this really supports this concept of like at the heart of everything that we do, no matter where you work in PT, no matter who you think you're treating a human at the heart of it, like at the core of it. I'm not going to use heart because we're already talking about heart. But at the core of it, you have a human being who is experiencing a whole lot of things all at the same time. And again, if this isn't further evidence to really support and demonstrate why this is such a necessary conversation, like, I don't know what is, y'all. Because again, The majority of my patients, I'm thinking just on my caseload right now. Right now, I'm seeing a lot of patients who are post reconstruction, who are experiencing lymphedema after breast cancer, treatment and whatnot. I think all of them are moms and have given birth at least once at this point and are at different stages of like how long ago that was. But it's like I interviewed Dr. Alex Hill a few months ago, and I made the very offhanded joke of like, one in one patient has a pelvic floor. So like everybody's got a pelvic floor that we're working with. We cannot exclude it, just like we wouldn't exclude your patient has a heart, your patient has a skeletal system, your patient has a digestive system, your patient has a brain. Like all of this comes together. And I know for so long I was doing such a disservice because I wasn't thinking about the whole like pregnant postpartum thing because it just scared the pants off of me. So when we get into actually working with these patients, one of the things that immediately comes to mind, I actually had this question from a student last week and is like, is it actually safe to treat a pregnant person? Which I think I know the answer, but we're going to dive into that more. So, is it actually safe to treat a pregnant person who is also a quote cancer patient, right? Who is going through cancer treatment? Can we talk safety for a bit?
Oh, absolutely. And when I think of that question, it makes me like ask probably 10 questions, which I'm not supposed to do, right? You're not supposed to answer a question with a question. But I do. I like have now a bunch of questions like, well, what do you consider treatment to this population, right? So they're
Mm-hmm.
pregnant,
Mm-hmm.
they have a cancer diagnosis, and now you want to treat them. Well, what are you treating? Right.
Mm-hmm.
And so what I'm finding is that a little bit of the frustration I was feeling, I'm not feeling it as much anymore because I just realized, well, this is just a conversation,
Mm-hmm.
right? Because we're trying to make so many decisions before we even walk into the room to where we now talk ourselves from walking into the room at all. We talk
Yep.
ourselves out of it because we're
Yep.
trying to plan so much around what a treatment session would look like with a pregnant person who now has cancer that we don't even
Mm-hmm.
have the conversation. And so
Mm.
once we actually stop and pause and say, oh, you're having this issue, this issue, this issue, this issue, well, I can absolutely form a plan around that, but I'm going to have to pull in some team members, or I'm going to have a
Mm-hmm.
discussion with your OBGYN, or we're going to
Mm-hmm.
have to start looking at this aspect of your function and maybe make some changes here. And so then you
Mm-hmm.
start actually pulling yourself out. And I talk about this a lot on a high level with pelvic health therapists specifically. I'm having them pull themselves out of their practice so that they can start forming a team that takes on more things than they're able to do. And I say
Mm-hmm.
that for orthopedic therapists all the time. I say that to acute care therapists. I say that to oncology therapists, is that you're not going to be able to do it all. But if you continue to talk yourself out of even walking into the room, then you're then taking yourself completely off of the team. And that person
Mm-hmm.
needs a team more than anything. We're worried about the treatment. No, they need a team because they're going to deliver that baby eventually.
Mm-hmm.
We're hoping that what we can do is have them work towards a successful delivery, but we also know that if they're starting treatment, there's a high likelihood that they could also lose their baby.
Yep.
So we don't take ourselves off the team, not at any point. When they walk into our office, when they make an appointment, we stay on their team because they're going to need support postpartum, no matter what. If they have a baby that goes home with them, or if they don't. And that's the recovery aspect because we know with cancer, their treatment will likely continue throughout their postpartum journey. So when
Mm-hmm.
we're asking specifically, what do we treat? I can only answer that by saying we have to have a conversation. What is
Mm-hmm.
it they're experiencing? And if it's pelvic girdle pain, absolutely. Let's find something that helps them stay mobile or give them the support if that's the right type of treatment.
Mm-hmm.
If they're having shoulder neck pain because they're not moving their body and they're not really benefiting from joint impactful of reaction forces because they're not walking, they're not being active, well, then let's do something that helps them get into a better position. Can they get into the
Mm-hmm.
pool, or are they immunocompromised? It's all these things that we just have to then start using our physical therapy experience and
Mm-hmm.
work with that patient through.
We wouldn't expect our patients with cancer to go to one oncologist and be done, right? You know, they my patients are seeing a medical oncologist who's managing the chemotherapy, immunotherapy side of things, et cetera, right? We have, of course, our surgical oncologist, we have our radiation oncologist, and like that's not even all that they see. We know these patients are seeing a lot of specialists. So this changing in kind of the framework with which we approach these patients, I think is really, really important that Rebecca is saying of like, we're on a team. And even not just I, as the Onco PT, am on the oncology team, but we have this team of even rehab specialists who are showing up for this patient consistently. I mean, talk about kind of a paradigm shift from what I think a lot of the reality of Onco PT tends to be, right?
Oh, absolutely. At least you're like dropping so I hope your audience is really listening to what you're saying, the response that you're saying, the questions that you're like, actually posing because it's so important. When I was in practice, there was a rule that a patient couldn't see an occupational therapist and a physical therapist at the same time in outpatient oncology if the diagnosis was the same. Fair, right? Insurance was not going to pay for
Okay.
lymphedema therapy by an OT under their plan of care and a PT under their plan of care. Did it make sense? And so what we had to do is we had to be creative because we know occupational therapists focus on transitions to new routines and roles, which is especially important if you've just been diagnosed with cancer.
Mm-hmm.
You now have to adapt to a new routine and possibly a new role if you're also pregnant. And so an occupational therapist definitely needed to be on the team. If I, as a physical therapist, was really focused on the musculoskeletal function, guess what they were doing? They were focused on the daily activities, the mental health aspect, the medication management that this person now had, the appointments that they now had, the shift in their work schedule, the shift in their sleep schedule. So we just had to work together to find, well, what was the primary diagnosis that they were going to treat? What was the primary
Mm-hmm.
diagnosis that I was going to treat? And how did we configure this team around this person? And again, it comes back to communication. It's not the patient population that's the problem. It's the fact that we cannot seem to pull ourselves out of our practice and we feel like we have to do it all. And that's not oncology PT. That's not the field of
Mm-hmm.
oncology.
Mm-hmm.
Oncologists have such a vast team, and when you're a part of their grand rounds, everyone has a role. And we, as
Mm-hmm.
physical and occupational therapists, need to start using each other in our various disciplines and be able to share this load because there's not enough oncology trained physical therapists. We know that. So let's pull
Yeah.
in our orthopedic colleagues, our cardiopulmonary colleagues, if appropriate, our pediatric colleagues, if appropriate, if that person does have a newborn and now they are going to have care for their newborn or just managing those aspects of their newborn care as well as their own cancer treatment and postpartum recovery, we need to be able to make sure that we are developing a team that that person feels is wraparound care for themselves.
I'm going to pull something out that you just said because I mean, talk about a mic drop moment. We're configuring the communication and the treatment plan around the patient, not the other way around. And again, while this should not be mind blowing, I'm like I said earlier in our conversation today. It also is still kind of mind blowing because of just we've done things a certain way for so long, and of course we figured out it's not working, right? It could be better. It could be a lot better. This is how we really need to change things, and it's again, it shouldn't be earth shattering, but it kind of is to just how we've been doing things for so long when it comes to first of all pregnant patients, postpartum patients, but especially when we fold in this cancer diagnosis on top of this. Like,
Same. I treated in the Texas Medical Center, that's Houston, Texas, so a little bit
yeah.
south of you in Fort Worth. And uh, we had a mom who was being seen at MD Anderson,
Mm-hmm.
but yet she was transferred over to Texas Children's Hospital because she was delivering, but then having to go back for cancer treatment. And I realized that that concept of configuring a team, that really honestly is not something we're accustomed to spearheading as therapists, especially those of us who work in the hospital, because we're kind of just being fed orders and you know, and that's hard for outpatient therapists to really appreciate because we've worked so hard to be independent and direct access and this and that. And so working in acute care taught me a lot that not only one, is there so much more opportunity for communication and collaboration, there's actually a lot more opportunity for spearheading that communication and that team-based approach to care. There's nothing stopping me from contacting the PT at MD Anderson that this person is going to follow up with. Nothing, there's nothing, there's no rule. However, you're really starting to see that in different settings, therapists are being conditioned to the environment and to the practice that's standard there. And it's kind of a jolt when you give someone the permission to change that standard. And so, starting physical therapy services for women after cesarean section in the hospital as an acute care therapist, that's empowering. But what's even more empowering is making sure that that care continues beyond the point that they're going to see you, especially in the hospital setting. And then when you can do that on the reverse, as an outpatient oncology physical therapist, to then be able to make sure that that person is seen early on, who was your patient during pregnancy, who was diagnosed with cancer, and then maybe delivered by cesarean section, for you as an outpatient oncology therapist to configure their team and make sure they're followed up 24 to 48 hours after cesarean section or vaginal delivery because of the fact that they now have cancer and they're going to be going back for treatment. That is powerful beyond measure because you're now taking a role as a primary care provider. You're not just the physical therapist receiving orders for eval and treat. You're now spearheading the care of that individual on both ends of the spectrum during pregnancy and immediately postpartum, and you don't have to be in the room to do it all yourself.
I oh my god. I have chills first of all. And this I'm hearing, so I don't know if you've ever connected with Dr. Katie O'Bright. She's also a physical therapist, but she is like primary care. And it just, I mean, talk about worlds colliding. And what I love is that this, again, this is not centering PT as the most important professional within this paradigm, but is putting us in the driver's seat to make sure that, again, we are configuring that team, that care, and that communication around the patient. And honestly, I think PT and rehab in general are really, really good professionals to do this because we sometimes have a little more zoomed out because we're looking at, function and mobility and independence and quality of life. Not that that's not happening in other spheres, but we just have a different perspective. And I think what an amazing opportunity to show up and make sure that that patient is getting that care continuously, right? Continued throughout these very different phases and transition periods for this patient experiencing such a multitude of things happening. Like, again, thinking back to pregnancy, but then also the birth, and then the postpartum, and then we've got cancer layered throughout all of this. Like, holy cow.
Exactly. The only thing I would probably challenge on what you just said was
Love
that
it.
we're not the most important person on the team. I would challenge that a little bit.
Ooh, I like this. Oh, I like this.
I do. I mean, I would honestly just challenge people to kind of consider how big our role is and how much of a barrier we have to overcome within ourselves that wants to diminish our impact. And I have to like bring it back to a woman that I treated after birth, within weeks after birth,
Hmm.
who did end up having a mastectomy, double mastectomy. And what brought her to her knees, right? What brought her to the
Hmm.
point of just uncontrollably crying in my office was her trying to explain to me how difficult it was just making her bed, just making her bed. Like that, that was kind of like the tipping point where I saw her break down, just trying to explain something that was so simple before.
Hmm.
And so I often like think back to this now that we have data from 2022, that one of the most, and this is just so sad, but one of the highest causes of postpartum, either mortality, maternal mortality at this point, is suicide. And when we actually like sit down and really understand from their aspect, and we have to now take the most extreme example that we're talking about, that
Hmm.
patient who's been diagnosed with cancer, who
Hmm.
just gave birth, who then has a mastectomy or a double mastectomy, and the thing they can't do that's most distressing to them is their functional everyday activities. And when we're putting it into the context of that, that's not the primary care provider who can help them with that. That's not the medical oncologist that can help them with that. That's not the radiation oncologist who can help them with that. That's not even their care coordinator of a nurse who can help them with that. That is a direct relationship with their function, their ability to move part of their body because of the treatment that they're having, whether it was a major surgery, with the fatigue they're experiencing from chemotherapy, with the amount of restriction from radiation therapy. That's all of those therapies involved. And now the provider that is going to most likely make an impact on their physical function and their mental health from that point is us, is an occupational therapist and is a physical therapist. Because at that point, it becomes abundantly clear to the individual that this is affecting who I am and who I identify as, my role in my life, my control in my own life. And that's why I say and I challenge the fact that our role is a lot bigger when we're starting to really span out and look at people's long term mental health. What was the support that was given to them after diagnosis, right after treatment, such as a major surgery? Did we do everything in our power to prioritize their function as well as fight the disease from a medical standpoint? And so that's why I say if we're not coordinating a team early enough for this population, we're losing large amounts of opportunity to impact their long term mental health and their quality of life.
I'm kind of at a loss for words because when you frame it that way, I think, and maybe this comes from like my own insecurity and maybe like little imposter syndrome, which I know I'm not the only one. I know there's others out there who are feeling this, but like we may be saving lives and not in the like, here is your chemo that is going to cure your cancer. Like, obviously, there's life saving happening there. Obviously. And I think sometimes rehab has a tendency to be like, they save your life, I get you back to your function, or like, I, help you thrive. Sometimes that is life saving for patients. And again, the correlation that you're discussing between physical health and, function and independence and quality of life, and how that really impacts a person, not just in the now, but like you mentioned, long term, right? Ideally, our patients are going to be living for 10, 20, 30, 40, 50, 60 years after their cancer diagnosis. Is this always the reality? No, but this is what we're hoping for, right? And it's not just a little thing now. It may be a little thing now, but that compounds over time. And we know that these patients can have a lot of long term issues, late presenting issues. And to think that we, as the rehab professional, may be helping to save their life in that aspect is a really, really cool thing to think about. And I'm really glad that you stopped me and challenged me on that, because I don't know that I would have made that connection. Genuinely.
It's so true. A lot of us don't. I tweeted this a few weeks ago and I thought like really hard before. I do. I'm very thoughtful in what I put out into the universe. I
Mm-hmm.
don't really tend to err on the side of just fanning flames and getting attention. But there are some tweets where I know it's going to be a little controversial, and this was one of them. And so I tweeted about a therapist that was actually a preceptor to me to onboard me into acute care. And she said this quite a few times, but no one ever died who didn't receive physical therapy. And her reason for saying that was basically to just like let it be known, if we don't get to this patient, not a big deal, they're not going to die. That's fine. I mean, every profession can look at their role on the healthcare team that way. However, whatever helps you get through the day. But it was later on that I reflected that that wasn't just a day-to-day saying. It was kind of reflected really in her perception of the whole field. No one ever died who didn't receive physical therapy. And that really stuck with me several years later when I actually did intervene on quite a few number of occasions with oncology patients, with moms after birth, on finding things that were impacting and what later would be diagnosed in both populations as cardiomyopathy. And I realized, had I not intervened, right, when I did, or actually do the outcome measure that would have like then diagnosed them or then kind of caught that there was an issue with their heart rate variability. There was an issue with their heart rate recovery. They were not coming down off of that sympathetic response. You know, they were at a max in terms of their energy expenditure that I otherwise would not have caught had I not run through those tests, have I not listened to their symptoms, all of those things. And that made me really start to dial back and dial back and dial back and say, wait a minute, we do have a life-saving role, but a lot of us are missing that opportunity in that window because we've diminished our impact on the team by weeks at a time, even months at a time. And so I realized I needed to educate the acute care therapist, the oncology therapist, and outpatient, the other therapists that didn't really understand their role in this person's care. And I needed to educate them to start taking a larger role, a larger picture of the downstream effects of waiting too long, waiting until the order 3 months down the road for someone who has now lymphedema when we could have treated it early, waiting down the road with someone who now has cancer-related cardiac issues when we could have treated them early and taught them how to modify their activity, how to reduce their energy expenditure. And that could have actually bought them years. That could have intervened in their life. That could have helped them really avoid a lot of complications that did cut their life short. And so, again, it really has come down to understanding the scope of my practice, and it gets a lot larger when I'm able to actually build a team that can do the things that I cannot do. But yet I'm spearheading that effort like we would see a primary care provider do, which is why I'm such a fan of Katie O'Bright's work. That primary care physical therapy doesn't mean you're taking your specialist hat off. It just means that you're now seeing yourself as a bigger component of a healthcare team. And you're able to navigate a lot more issues and help your patients navigate a lot more issues by building an even bigger team that can handle a lot of their concerns way earlier than you would had you waited for the order weeks and months down the road.
I love this so much. Like, I, you've just, you have turned on a switch in my brain, Rebecca, of I think where this conversation needs to continue. Like, not just in the future, but I mean, how can I really implement this in my practice? Which I have something I've been working on behind the scenes. I'm not going to share a whole lot about it, but I am moving into a position where I am going to be very much integrated within the oncology team, like an oncology team locally. And what this has started in my brain as not just the podcaster here, but as a treating physical therapist is like, how can I make that happen in my area? Because I was literally, right before I got on the phone with you, had a conversation with somebody about how, y'all, I hate on Fort Worth healthcare wise. I love living in Fort Worth. Like, I live here for a reason. But it's really disheartening week after week where I'm getting patients coming to see me who are like, I wish I would have known about this when I went through treatment. I wish someone would have told me about lymphedema 8 years ago when, like technically this all started or whatever. And I'm what you have really turned on for me, Rebecca, and I'm really, really grateful for this, is how can I take this and just apply it in my own practice now that I'm moving into this role. Anyways, stay tuned. I'm going to figure that out. I'm going to report back at some point. But it's really, really exciting to think about the kind of impact I could have on patients in that way. And I'm really, really grateful that you have flipped that switch in my brain for me.
Absolutely. And I mean, I'm not going to pretend that I know your practice in and out, and that, you haven't been doing this. So I'm, just take it as me just giving my 2 cents.
Absolutely.
But your podcast is already doing that work for you. Like the fact that you have created a platform where someone can now learn another branch off of oncology PT that now extends services to a mom who's been diagnosed with cancer, who is about to give birth, or who has given birth. You're already doing that. And so that should not be diminished at all. The fact that you've created now this platform means that in part of your practice, you might actually have now a segment of your practice that is dedicated to educating OB providers who
Oh my
have the
God.
occasional patient who's now been diagnosed with cancer. And
Mm-hmm.
they don't even know physical therapists can treat that person in the hospital after birth. Well, you're a physical therapist that treats individuals with cancer in the outpatient setting. Now you've educated this OB care team. Guess what they've done? They've widened their team to include a physical therapist in the hospital that helps that mom recover within 24 to 48 hours after delivery. And then that mom is not waiting weeks or months on end to come back to you. No, they've set her up with prehab before cancer treatment that she's going to receive now postpartum. This web that you're creating just with one episode now branches off into all of these little tiny segments that really start to build systems of care like we've never seen before. You're doing the work that 98% of the population does not do. Most PTs probably are absolutely happy graduating from school, given their assignment, whatever that is. If it's the specialist area, they're going to receive their influx of patients and their referrals, but they're not thinking building programs, extending
Mm-hmm.
into different avenues, creating something that doesn't exist. Most people
Mm-hmm.
would be happy to clock in and clock out and be done. Love their children, live life, go on vacay. You are spending time and energy into creating a platform where people can now imagine care differently for a segment of the population that doesn't receive standard care, right? And I'm going to say this for my orthos that may be listening.
Mm-hmm.
You have it made. You have it made with a population where you know after a joint replacement surgery, they are most likely same day of surgery or within 24 hours going to see
Mm-hmm.
an OT or PT. You have it made when you know that person already has been prepped and prepared on what their first day with you is going to be like after a knee replacement. You have it made when you have providers who do not fight you on sending their patients early before surgery and then early after surgery, after a joint replacement or shoulder repair or an ACL repair, whatever it is. But for the rest of us who are trying to get that same level of early care for our patient populations, we're trying to catch up to you. So if you can help us, please do. Please, please take off some of this load, especially when that person is fresh outside of a mastectomy. That's a
Mm-hmm.
shoulder issue. That is
Right.
not lymphedema.
Right.
Not yet.
Yeah. Hopefully we don't get to that point. However, you and I know better, right?
Yes.
I am so deeply appreciative of that, Rebecca. Like, I think I'm going to have to save that soundbite and just save it on my computer somewhere where I can listen to it at least like once a week. But you touched on, like, and I would be absolutely kicking myself if we did not, like, you have provided a tremendous amount of information and wisdom within this episode. And I sincerely hope that there are listeners right now, you listener, who are tuning in and thinking, I'm really fired up about this. And I'm really excited, and I know that I have more to give to make this happen, but maybe I just don't have enough information or I'm not comfortable with that information. What resources, what continuing education recommendations do you have for the clinician who is like, I need more, I want more, where do I get it?
This would be a great conversation, or a great opportunity to like pitch my programs and things like that. But it honestly, it's like
Well, give it to me
it
also.
feels so, it does. It feels like there's even more basic information that I don't know if it's been created yet. I feel like we're all working on pieces of it,
Mm-hmm.
but I'm actually going to take the opportunity to pitch people that are inspiring me. Katie O'Bright. I have to just take a moment to just say what an impact just a webinar I went to recently on primary care physical therapists had on me. I said, oh my
Yeah.
gosh, this is what I've been doing. Like, no wonder I've been frustrated as a women's health therapist because I feel like I'm working so late.
Mm-hmm.
Way after that person now has incontinence, now has pelvic pain, now has, issues from cancer. And I'm now seeing them months after the fact. When I knew in PT school the four phases of tissue healing and the remodeling phase that had already been, for the majority, completed by 3 months, and I was seeing them at
Mm-hmm.
6.
Mm-hmm.
So I almost feel like if we actually took a step back, yes, I teach acute care therapists how to treat individuals immediately after birth and also during high risk pregnancy who are in the
Mm-hmm.
hospital. But I feel like there is a bigger issue here that's affecting individuals during their cancer diagnosis and treatment That's affecting mothers during pregnancy and immediately postpartum. That's affecting women in general, individuals after female specific surgery, like hysterectomy, whether it's cancer related or not. It's a bigger issue that I think really speaks to our culture of how we're segmenting different areas of the population or even in our education. I see it in DPT education too. This year was tough to be in a DPT program and seeing how we're prioritizing patients, not because of their impairments, but of their diagnoses. When did that happen? When did we become a profession that is focused more on the diagnosis rather than the impairments that someone is experiencing? You're okay to treat someone after a rotator cuff repair, but you won't ever look at someone after a mastectomy because that's just not your area. That's not your diagnosis. The impairments
Mhm.
are the same. Even more so, that person now has a cancer diagnosis. So we should be doing wraparound care for their mental health as well. Like, why are we
Mhm.
not teaching that in our DPT education? So when people are asking for more courses, I think you should start listening to podcasts like this. Like, sit in your car and turn on the Onco PT and have a conversation now, truly, with your colleagues wherever you are. And just start to do a self assessment of your own practice. Are you excluding patients who could benefit from your early interventions because of their diagnosis? And you're talking yourself out of even walking into the room and having a conversation with them. You only see incontinence, but you don't see the potential musculoskeletal components that might be causing them to have now bladder or pelvic health issues. And your PT colleague, who's a pelvic health therapist, has a 3-month wait list. And just so you're okay with having that person wait longer, you're not even going to have a conversation with them. Or the pregnant mom who now has cancer. You've talked yourself out of even treating them. I think we just need to have a conversation. All of us are after more courses, more credentials, but we're not having conversations around our culture and how we're treating people.
I'm kicking myself that I've been doing this podcast for almost 5 years, and this is the first time I've had you on because this episode has absolutely been one for the books, Rebecca. And I will definitely be inviting you back sooner than later because I feel like we have just, I expected genuinely, which is my own preconception, right, of what was going to happen. I had this list of questions. I was like, this is the information I'm looking to get. I'm looking for it to be nice and clean and wrapped up in this like box with a ribbon on top. And what has happened, what has transpired in this conversation is way more than I could have asked for in the best way possible. And I feel like I did not get that, like Elise yesterday was like, I have a list, I have a checklist I'm trying to check off. And what I have learned today, and again, this conversation has unlocked things genuinely in my brain of we have just started. We have just started. And instead of being discouraged, I'm very hopeful. And I think I'm starting to form an action plan. And I hope that my listener is also doing this of like, this has given me an idea of where to start. And I'm going to start that. And I think that's all that we can ask for of ourselves genuinely as you, the PT or the OT or whoever is listening to this. That is all we're asking is what is the one step that you could get started with today to start making this a reality for your patients. I think that is my takeaway from this episode of like, I am frustrated, but I am very hopeful and I have an action plan going to fight that frustration and those barriers that we're experiencing in OncoPT, especially healthcare in general right now. For the listener who is like, I need to follow Rebecca ASAP immediately yesterday on all the things, where can people find you online to keep learning from you? Because this was, oh my God, y'all, this was just the start.
Yeah, no, this was great. Absolutely. I cannot echo this enough. This is the kind of conversation I want to be having every day. And so I have some of those conversations through um, a company I created called the Pelvic Health Network. It really is just a conglomeration of in education that really makes pelvic health, women's health education accessible to everyone.
Mm-hmm.
So I'm
Mm-hmm.
often pulling in outside people that are not healthcare providers to really give more insight into what's going on culturally that's creating
Mm-hmm.
these barriers that you and I are talking about, right? And
Mm-hmm.
so, Pelvic Health Network, you could just find me looking up my name. Seems to be the hardest name ever. People are putting a double C or an A in my last name. So it's
I
Rebecca
did that. I
Segraves.
absolutely did that.
But
That
if
was me.
you
That
honestly,
was
if
me.
you write it phonetically, it should probably get you to the right place. And so, Pelvic Health Network, Rebecca Segraves, Enhanced Recovery After Delivery, that is just a passion project. That's really, it has me working with more teams across the country and Canada than I could have ever done had I just stayed a therapist in the clinic or in the hospital. And so we are creating more programs that offer OT and PT in the hospital after birth to any individual, no matter the birth experience, no matter if they also have a cancer diagnosis. We're just getting them into rehab early on to
Mm-hmm.
prioritize their function as well as their medical treatment. And so, enhanced recovery after delivery, I'll be working on that until the day I'm no longer a therapist, and that may be the day I close my eyes, but really happy to be doing this work. Thank you.
I will, of course, link to all of that in the show notes so you'll be able to access that. Like I said, I've been following Rebecca at least on Twitter for a good chunk of time. And I swear, every other day, you're posting on there, and it's always just these mic drops, and it's not even necessarily an answer always. But it's funny. We kind of began this interview with like, well, I could answer that, but I would need to ask him more questions. I think you're almost turning that back on me as the viewer of your information you're putting out is like, you might give me a snippet of information, but what that then causes me to do is ask more questions of how can I actually take this and implement this in my practice? How would this apply for my patients? How can I take this world of the pregnancy and postpartum side of things and then integrate that into oncology, even for my non pregnant postpartum patients, right? And so I would really, really encourage you, like, if you do nothing at the end of this episode but follow Rebecca on Twitter, you're going to be a better therapist for it. And I would really, really encourage you to do that. So everything will be in the show notes. My God, Rebecca, this was incredible. And I am so, first of all, I'm tickled to death that I reached out to you yesterday and we made this happen like within 24 hours because that was amazing. Definitely will be having you back because this was phenomenal.
I cannot wait to be back. Same here, Elise. Thank you. Thank you so
Oh
much.
my God.